Welcome to the IGIE podcast. My name is Neil Sharma. I'm the chair of the editorial board for IGIE. Today, I'm joined by one of our authors. Naina, could you please introduce yourself?
Thanks, Neil. Hi, I'm Nayantara Coelho-Prabhu. I'm an associate professor of medicine at the Mayo Clinic in Rochester. My interests clinically and in research are in the diagnosis and management of dysplasia in inflammatory bowel disease. And so that was the basis for this article, for this manuscript, and why we decided to further investigate the possibility here.
Can you tell me about the name of your article, some of the co-authors?
The article is the development of an artificial intelligence tool for detecting colorectal dysplastic lesions in inflammatory bowel disease. We had a large team work with this, led by one of our fellows, our gastroenterology fellows, Dr. Daniela Guerrero-Vinsard. And we had a number of physicians that were helped with the annotation. We had our own data scientist, Jeffrey Fetzer, who did a lot of the analysis. In fact, he did all the analysis, and he developed the original CAD-E tool that we'll talk about when we talk about the study design. And we developed that in-house and then went on to refine it to detect dysplastic lesions in IBD, which morphologically can be different than in non-IBD patients.
Amazing. Well, tell me a little brief overview about the work and the article itself.
Sure. So what prompted us to do this was the fact that at Mayo in Rochester, we have the largest IBD surveillance colonoscopy cohort. So we do about 700 to 800 procedures a year just for IBD surveillance. And a lot of these patients return. And because I primarily do a lot of these procedures, it was really interesting to me about how the field of CAD-E, or computer-aided detection, was exploding in the non-IBD sphere. But in IBD, these lesions can be quite hard to differentiate from benign lesions, and also sometimes really hard to identify because the morphology is very different from others. And so initially, we were developing our own in-house CAD-E tool, initially as a proof of concept sort of thing, to see what we could do with our own data set. And so we developed this using a large set of non-IBD polyps, and we ran it and tested it in our own data, and it did pretty well. And so when we decided to adapt it to IBD dysplasia, initially we annotated over 2,000 images of IBD dysplastic and non-dysplastic polyps. There are various histologies of polyps. So there's dysplastic. We also had non-dysplastic, serrated lesions, and pseudopolyps. Once we had the annotated images, we then ran this system just directly into our pre-trained CAD-E system that was trained on non-IBD polyps. And we found it really didn't do well. And this was done to test the hypothesis that you cannot just apply a standardized CAD-E algorithm to IBD patients. It has to be retrained with these images. So as the second step to the project, we then we divided that set of images we had into an 80% for training and 20% for validation. And the 80%, we then retrained the CAD-E algorithm that we had developed utilizing these images. And then we ran it again, and we were able to show a significant improvement in the sensitivity and the specificity and the accuracy of the algorithm. Now, bear in mind that this was done with images. It has not been run in videos yet, but that's the next step. As a proof of concept, we felt this was really quite impactful, and is the first publication in this arena.
How did you work with software engineers or computer engineers around the AI design for this? There must have been a precipice on which you built the AI design of the deep neural network.
So the deep neural network initially was trained, like I mentioned, on this non-IBD system. And he used a system called DarkNet 53 system and developed the basic CAD-E. And then it was a YOLO 4 system that he used to upscale and change and retrain that with the IBD images.
How do you think this will impact future clinical work? Are we far away from it? Is it the early stages since it's not adapted to video? Was this a big leap forward?
I think it was an exciting leap forward, at least for me, because it's what I'm interested in. But I think it also will serve our patients significantly. We've had some significant findings from the study. What we found was that it does great, the CAD-E, to detect polypoid lesions. Well, the basic framework, even after retraining, was in non-IBD patients where lesions are more visible and more polypoid, but it didn't do well in flat lesions. And so I think the algorithm will require further refinement to detect flatter morphologies, which are often found in IBD patients. Even among IBD flat morphologies, there are the ones that are overtly malignant, but very often, because of our highly advanced endoscopes now, we find what we call serrated epithelial changes or flat areas of mucosa that look different. And I think this, once we are able to identify what the impact of those lesions is down the road, that's really going to affect patient care. And so I think in terms of how much we can serve our patients, this is going to be a significant leap forward. I think it's exciting if you're in the AI space because, again, like I said, very few, this hasn't been done before. There's now a more recent abstract at DDW that will talk about another from the UK that looked at IBD dysplasia. So I think it's going to be something that many people are interested in. I think what you're going to need, though, is very large data sets because it's such a difficult morphology to identify. And these patients are not as many as screening or surveillance colonoscopy. So I think you're going to need a big set of patients to really, and data to develop this in a fashion that is accurate and applicable.
All right. So if someone's going to walk away with 3 key points from your article or your research and the work that you've done, can you boil it down to 3 key points for us?
So I'd say the first one is that a standard CAD-E algorithm can't really be directly applied to IBD with the same sensitivity and specificity as in a screening or surveillance population. The second thing I'd say is that we really need to develop large collaborative data networks to provide large volumes of these images so that we can train a system to further identify these. And the third point that we actually learned by developing this is how important it is to clearly define morphologies in IBD lesions that we can visualize, and how important it is to follow those outcomes so that we can really see if everything that we see, now that we can see so much, is really meaningful or not.
Yeah, I think this is really exciting work. To be honest with you, I've written a couple of articles in the past year or two on AI and its role in pancreatic cancer and specific EUS images, which are often operator dependent. So this kind of flattens that curve or that distribution with operator dependence. And this sounds very similar. And then one additionally on pancreatic biliary cancer. So I personally find this really exciting work. What made you interested in this particular arena of research in AI, and why is research as a whole perhaps important to you at this point in your career?
Sure. So I think, I started off primarily as a clinician, but again, I think it's really helped me to focus and hone down on what I want to do in terms of my research. My clinical practice is IBD. We, again, being a tertiary referral center, we get a lot of cases of patients with dysplastic lesions that are sometimes missed or are difficult to identify. So I like the challenge of being able to perform these enhanced imaging techniques, be it dichromoendoscopy or virtual chromoendoscopy in this arena. And that has then led to, it opens up, I think, more research questions of what we can do. And then that's how we progress to this. In addition, like I mentioned, because we have this extremely large cohort of patients with surveillance colonoscopies, it has allowed me to create a very large data set that we keep, it's a prospectively collected, we keep collecting this. And so we're going to have an ongoing database. The other thing at Mayo and Rochester that we're doing is initiating universal recording of all procedures. And so we're going to have all our procedures recorded in the near future. Wow. And linked to clinical and pathological data. And so we will be able to really accelerate our development of AI assisted products in the near future, because as you know, in the field, having still images is great to start off with, but you really need to train and validate on video data. It's a great time to be here. I think and a great time to be in the field because of where the whole industry is moving, the accelerations in technology, and it fits great with my clinical interest. So it's very exciting to me.
The work that you're doing, I'm sure, will be the backbone of things that will affect the way that we practice in the future, in particular AI being implemented to our everyday practice. And I certainly can imagine that to reduce some of the operator dependence and operator variability, particularly in really complex lesions, as you pointed out in IBD, where sometimes sensitivity and specificity of where we biopsy can really be affected by having some other enhanced technology point these abnormal lesions out. So I
Absolutely.
appreciate the work that you're doing. It's going to have a big impact.
Thanks, Neil.